Hi, and welcome to Centra Scripts. My name is Cami Smith, and I am here with a group of us who get to not just tell you about an incredible surgery, but also get to share a story of a patient who experienced that surgery and had a big life change as a result. I am here with Robyn Greenstein,
Hi.
who is a patient here at Centra, and you've experienced this particular surgery. And we also have both of her surgeons here. And so we have Dr. Henry Wilson and we have Dr. Peter Ploch, who are going to talk about the more technical, the more clinical side. And I asked them very specifically because I want to be careful to make sure I get the names of the surgeries correct, because it really is amazing what you guys have been able to do. Bilateral nipple-sparing mastectomy. And so many of us are very familiar with a mastectomy, but this is a very new side of it that many of us have not heard of. So we're going to talk through about it a little bit today. But first, Robyn, why don't you tell us a little bit about yourself and then just the beginning of your journey?
Okay. So I grew up in Virginia, in Northern Virginia, and my husband and I made our way down south to Florida and decided to move back up. In February of 21, we moved back up, and then actually on my husband's 40th birthday, less than a month later after our move, I found a lump during my monthly self-check. And because of a family history, my mom had had breast cancer, my grandmother had had breast cancer. I was expedited basically through everything. And less than a month and a half after moving back to Virginia, I was diagnosed with breast cancer, stage 2, at age 36 with
Wow.
2 young kids. And it was hard.
Yeah. And so you were doing a self-check. This wasn't like going to get like your regular scheduled mammogram. And because of that family history, is that something that you were doing on a regular basis?
It was. Ever since I was 30, I would periodically get mammograms anyway. And this one, I was like, oh, it's probably just a cyst like I've had before. And I asked my husband to feel it, and he goes, no, that feels different. You need to get it checked out. So I like to say he saved my life.
Oh, I love that. Well, and that's a big deal. You listen to your body, you listen to your husband, but I'm sure also stepping in and bringing your provider into that conversation. What did that next step look like?
Because literally it was less than a month after we moved, I just called around to different gynecological offices and asked them, like, hey, what's the earliest space you have? I found a lump in my breast. And I found one that could squeeze me in 2 days later. He's like, yeah, doesn't seem like much, but better safe than sorry with your family history. So had a mammogram. They actually had a cancellation like the very next day. So I was able to get squeezed in there. And I could tell when they were doing more imaging, I was like, this is not good. But then I had the weekend. Oh no, then they were like, we have to do a biopsy. I was like, okay, that's scary, but it's a biopsy, no big deal. And then the following Monday, it was literally 5 minutes into my planning period, I got the phone call that it's cancer. So
That's so you're a teacher. So you got this call at work.
yes.
Did you stay? I mean, I know this is a big part of your story. Like, did you stay? How did you process that?
I'm very much the type of person that needs to stay busy. So, like, when my mom had breast cancer, she had ductal carcinoma in situ, and she hates that I say only had to have a mastectomy. But sorry, Mom, it was just a mastectomy. You didn't have to go through chemo and everything, too. And I worked, I was in college, and I threw myself and got best grades I have my entire college career the semester that she was going through treatment. And I threw myself into work, and my principal's like, hey, do you want to take the rest of the day off? I was like, nope. I'm going to work through this.
Yeah. So you pushed through. Okay. So you went through treatment. At what point did you make the decision to get the mastectomy?
It's actually kind of funny. I remember asking Dr. Ploch, I was like, if I was your wife or your sister or your daughter, what would you say?
That's a huge question.
The answer that I'll give to that question differs from time to time.
Okay.
And sometimes I'll say it's not a fair answer because everyone brings a different set of things to the table, and sometimes the answer, if you're a mom or if you're an aunt or if you're a sister or your wife, might be a different answer.
Yeah.
I honestly don't remember exactly what I told you, but I do remember looking at the big picture and seeing what you had to go through and seeing how young you were and knowing what a lot of women your age have had to deal with in the past. And I felt like the best answer for you was to get through your chemotherapy, shrink that thing down, and then remove both of your breasts.
I remember you saying that given the family history, given that it was HER2 positive but hormone negative and how aggressive that is, that my best option for reducing recurrence would be a double mastectomy. And I was like, okay, then let's do that.
And, for someone at a young age having to go through this once, you can imagine, even if that chance on the other side is 5% or 10%,
Yes.
no one wants to do that again. So at a very young age, a very reasonable decision to have both breasts removed. The next part of it, though, was with her type of cancer, there's not a guarantee, but we knew with pretty high degree of confidence that she was going to have a really nice response to chemotherapy. So nice that it's not unreasonable to expect that it would all be gone when we operated.
Okay.
And so, she's young, she's healthy,
Yeah.
no reasons not to offer the best possible operation we can
Yeah.
give for cosmesis, which is a bilateral nipple-sparing mastectomy through hidden incisions.
Okay.
Do the first step of breast reconstruction that day. And she asked me a question, and she said, because you actually brought it up, and you said, well, what about sensation? Am I going to lose sensation to my nipples? And I said, well, it's interesting that you ask because I have a plastic surgeon who I work with all the time, and he's interested in starting the program. And since you're starting on the chemotherapy now, we are likely going to have a fair amount of time to prepare for this.
Okay, that's incredible because you were just telling me before we started recording that you have really learned to advocate for yourself.
Yes.
And to have the confidence to ask that question when you didn't even know this conversation was happening over here. Like it's just so incredible how that worked out. And this is the first surgery that was performed was with Robyn, correct? One of the first at our hospital.
Correct.
Wow, that's incredible. Before we jump into what that looks like, why don't the two of you tell us a little bit about your history, what brought you to Centra, and what led you to this moment where you came together to do this surgery?
When I left here after high school, I had no intention of coming back. Let's be pretty clear about that.
I hear that a lot.
And after my second child, it became a very attractive place to move back to for quality of life, for cost of living, for a stable hospital system. Really, Lynchburg had everything we wanted. And so, I did my surgical training in Buffalo. I did trauma and general surgery there for 3 years after graduating from my residency program. And so 15 years ago, moved back to Lynchburg. And I had done, the requisite breast training in residency at Roswell Park through rotations. It wasn't really the biggest part of my practice. But after I moved here, I started getting a number of referrals for breast cancer cases. I was getting good cosmetic results. We were getting really good, technical results, and the referrals just started to build and build. And so now it's more than 50% of my practice. I couldn't be happier.
Wow. Okay.
But you moved here a couple of years after me.
Yeah, I've been here since 2010. So I moved here when I moved here, there was no one doing immediate breast reconstruction. So it was kind of an open field, open market, and an opportunity to build things. And I had done a breast fellowship at Georgetown, and I was sort of looking for that sort of thing. And so it was a great opportunity from that standpoint. So I got here and we started, the best thing for a woman is to be able to do an immediate breast reconstruction. And immediate means reconstruction at the time of the mastectomy. So when she's put to sleep for the mastectomy part, when she wakes up, she has a complete reconstruction or at least a start towards that. So we set out to build that, and that's how I met Dr. Ploch, and we started working together on cases. And so we just built that over the years.
And so he's been a great partner for innovation. And, I'll go to a conference and I'll come back with an idea and say, what do you think about this? And then he'll come back from his conference and we'll work together toward that goal. And it's been an evolving process over the last 10 or 12 years. And I know that we did the first bilateral nipple-sparing mastectomy together. We did the first Goldilocks mastectomy together. And then we did the first nipple resensation together. And, every few years we're adding something else to the armamentarium. But not every lady is a candidate for the operation that Robyn had. It's, not to say it's the perfect candidate, but you do have to select carefully. We've kept our infection rates very low, our re-excision rates very low, but a lot of this is based on careful patient selection. But
so you had an incredible team
Yes.
at your disposal.
Yes.
Which is really, it's the best case scenario.
Mm-hmm.
So what are some of those considerations in choosing a candidate, or when even suggesting to a patient that this is an option? Because it sounds like an incredible option, but you obviously don't want to make a suggestion if someone's not going to be a good candidate.
Well, there are a few from my standpoint, and then I'll let you cover yours. But from a starting standpoint, there are some ladies who are having mastectomy performed prophylactic. Maybe it's BRCA1, BRCA2, or another inherited deleterious mutation where they have an extremely high risk of breast cancer. And you're operating and there's no cancer in the background. It's purely prophylactic. That's one indication. But as you start marching along some of these diagnoses, if you have someone who has a cancer that's too close to the skin, maybe they're not the best candidate for a nipple-sparing mastectomy.
Okay.
If you have someone who has to have surgery first and then chemotherapy afterward, maybe that's not the best person for reconstruction. You don't want to do this large operation, introduce an implant, knock out their immune system with chemotherapy, have them get an infection, and have it go sideways. So we really avoid situations like that.
Yes.
From your standpoint?
From my standpoint, there are a number of technical aspects we have to consider, and first and foremost is always the cancer treatment, which Dr. Ploch covered, but secondarily, there has to be appropriate size considerations. So from my perspective, the breast can't be too large because the graft only comes in 7 centimeter maximum length.
Okay.
And that ends up limiting things to a certain size. It's still a very reasonable size, but if because the size of the nerve graft is limited and the length of the nerve that we're able to preserve at surgery is also limited, there's an upper limit.
Okay.
So a breast that's too large or a breast that's too droopy, it just doesn't work technically. And those are probably the biggest considerations.
And the other ones that go into it too are the smokers are not a good candidate. They have a double risk of infection, delayed wound healing. So active smokers aren't a good candidate for nipple-sparing mastectomy or immediate reconstruction.
Okay.
Someone has diabetes whose diabetes is under poor control. And then there's also a general cutoff for the body mass index. There's a inflection point where the risk of infection goes way up. And so those are some of the other considerations.
Yeah. So some healthy, like taking care of yourself, preventative type things that need to be taken care of before you step into something like this.
Yeah, a lot of times I'll tell patients, like, you're looking for someone who's going to do a really good job for you, who's going to take great care of you. You also have to take really good care of yourself too. Yeah. And so you have to look internally and say, well, these are the things that I can do to make myself a lower risk for surgery. And it might be quitting smoking or, some attempt at weight loss or better control diabetes.
Okay. So is it an option for them to wait? I mean, when you're thinking about cancer, sometimes it's not an option to wait to get those things taken care of.
No, a lot of the complexity comes with what other treatment the lady's going to have. If she's going to be having chemotherapy, so is she having chemotherapy first? Well, then she may have a 4 or 5 month delay before having her surgery, which a lot of ladies are able to actually quit smoking during that time period and remove that one risk factor. So there are ways that they can.
Okay.
Mm-hmm.
Wow. And so this really can be a proponent to help people make changes that will also be great long-term changes. So you obviously came into this equation having considered this. But what was that decision like when you were deciding, when you were wondering, is this an option? You found out that it was. So just walk me through that process for you.
So, about 15 years ago, when my mom had breast cancer, I actually took her for her first. I was there when she had her surgery. I was in the waiting room with my dad, and I was there for her first expander fill appointment. And, so I had seen some of it before, and so I had seen and it was a total mastectomy. So it was just the scar going across the front. And so I was like, okay, well, if this is what's going to prevent me from having to go through this again, and this is what's going to prevent me from not going to my daughter's softball games and being out half the time because I'm too sick to get out of bed, it's worth it to have the mastectomy. And I already knew kind of knew what to expect from seeing my mom go through it.
Yeah. So what made you want this surgery? Not the mastectomy, but
the resensation?
Yeah, the resensation.
It's gonna sound really weird, but my anxiety.
Okay.
Because I'm very aware of my own body, like the fact that I was able to find the tumor when it was only I don't know, what was it, 2 centimeters or something like that? It was like the size of a peanut.
Wow. Okay.
To lose any part of that was, to me, more devastating than having a chance at having partial feelings still.
Yeah. Well, and you were talking about things like feeling your child's hug.
Yes.
That's huge.
Yes. I have friends who have not had resensation, and they're like, I must have hit something today because I have a big bruise on my chest and I have no idea where it came from.
Oh, goodness.
And I'm like, I don't want that for myself.
Oh, no. And so the fact that this is even an option, and it's new, so I don't want to misspeak. The second in the state of Virginia, is that correct? Or the first surgery of its kind?
We were the first that did this in Virginia.
So this is the first surgery of its kind in Virginia. What does that mean for our area? Like, is this something that you foresee really growing in interest, or has it already? I mean, as word is getting out, I'm sure that this is something that women are going to want to jump on to just for their life.
I mean, I think it has automatic built-in appeal. If you're aware of that as an option, you're probably going to want that. I mean, I think it's as simple as that. And if you can, I mean, we all want the best for ourselves or for our family members, and if something like that is possible, and after considering whatever the potential negatives are, if it still seems like a great thing, then people are going to want that.
Well, and I would assume it would become a standard moving forward for those that for someone who is a candidate for it, this is just something that should be a part of the process. Is that, forgive my ignorance, is that how this works?
So, from our standpoint, to back up a little bit, the, overall procedure that we do, we're placing incisions that are underneath the breast, in the inframammary fold, or an underwire bra would catch a lady in the breast.
Okay.
And it's usually about a 7-centimeter incision.
Okay.
And through that incision, what I'm doing initially is I'm separating the breast tissue from the entire overlying skin envelope.
Okay.
And then separating the breast from the chest wall and pulling it out through that small incision.
Okay.
When we have to, we'll check a lymph node in the armpit through the same incision.
Wow.
If someone's having the other breast removed preventatively, usually on that side, we're not checking a lymph node.
Okay.
And then once I've removed all the breast tissue and I'm happy with my margins and what I've removed, then Dr. Wilson does the reconstruction. The added part for the nipple resensation is, as I'm removing the breast and the chest wall, it's the lateral fourth intercostal nerve that I am carefully dissecting out and preserving as much as I can for Dr. Wilson,
Yes.
obviously, as we go for the longer and longer lengths. And then what he does with that,
So from there, the nerve has to be prepared in order to connect appropriately to the stump on the chest wall. So that's an extra added step that we ordinarily wouldn't be doing. Each of those things takes time, and if we do it on both sides, it takes additional time. So those are all considerations. And sequencing becomes an issue too, because we're now no longer considering that we're putting an implant in and it's being held in place by a dermal graft. We're adding that implant plus the dermal graft, plus now we have a nerve graft, plus now we actually also have a little special connector that's connecting to the nerve graft. And what order do you put all those things in so that a little wrong move doesn't pull everything apart immediately, because it's secured by a suture that's like the hair on the back of your hand, a teeny tiny little thing. So for example, Dr. Ploch couldn't do a lymph node after I connected a nerve there. Well, he could, but he would then be worrying about that nerve getting popped off. Yeah. So there's lots of technical complexities that go
not
into
that I
it.
don't have a steady hand,
but it's very much so a partnership between,
right.
Yeah.
So, what he's essentially doing, though, is he's taking a nerve conduit or a nerve graft, and correct me if I'm wrong, he's plugging in the lateral fourth intercostal nerve to the conduit, and that is sutured to the undersurface of the nipple.
Okay.
And so what the nerve will do, it'll grow 1 millimeter a day along the conduit in an orderly fashion, and when it reaches the end, it just branches out like a root ball and attaches to the base of the nipple and restores sensation.
So what are some other effects after a surgery like this that a woman can expect?
In terms of what it feels like, or what?
Well, I mean, yeah. So you're saying
Complications,
that it grows until it does eventually branch out. So does sensation come back immediately, or eventually?
The ultimate authority on this is going to be our patient, but I will tell you from the scientific perspective of what we find when we study this on other people. There's two parts to it. There is sensation that returns along the skin from the outer part of the breast toward the nipple and areola, and that's creeping sensation that's present already, or that's not that doesn't disappear, that's regrowing naturally into the skin flaps. Okay. That usually does not go all the way to the nipple and the areola. Okay. But in 10 to 15% of people, it does. The second part of it is what we did, and that's the resensation of the nipple-areola complex. Okay. And those two areas will regain sensation, and then we know from testing with the little fibers that I, prod on Robyn and record every month or so after surgery, and as we judge the progress, we know that it comes in from the periphery inward, and then it also starts in the center and moves outward.
Wow, this is incredible.
Yeah, but Robyn is the ultimate authority.
So did you did sensation return immediately after surgery, or was it gradual? And what other, what does that feel like?
So it is more gradual.
Okay.
It doesn't because there's just that very little bit of the nerve, and then the conduit, is that what you would call it? The conduit, and the nerve having to go through the conduit. I called them nerve zaps. Okay. And I would feel them multiple times a day, starting a few days after the surgery, once I had gotten off of the more heavy duty painkillers and onto just regular Tylenol or Advil or whatever. And I would start to feel them more. And not that I've ever done this when I was a kid or anything, but the easiest way to compare it is by wetting your two fingers and then putting them on the top of a 9-volt battery.
Never done that.
Never done that. But it's a very sudden jolt.
Okay.
and it feels like a little bit of the electrical like tingle,
Okay.
like the old TVs that had like the static on it, things like that. But I noticed that they would come from the periphery and then come closer and closer and closer, and then I don't have them as much anymore. So when I do have them, it's like, wait, where'd that come from?
Yeah, catches you off guard.
It does.
Yeah.
I got used to it, and so it wasn't until my husband was like, have you had any of those nerve zaps lately? I was like,
No.
I don't remember the last time I did.
Yeah. Yeah. You're on the other side of it.
Yeah.
Yeah. So as we're looking at this as it relates to just cancer and how that impacts your entire life, this is, one small area where something doesn't have to change. But I also am curious, like, what are some other things that you hear from patients that are have had a surgery, whether it's from a mastectomy and getting breast reconstruction and just getting their life back and feeling a sense of normalcy? Can you tell us a little bit about, without sharing too much information, some of your patients and what being on the other side can look and feel like?
I get a lot of patients who will tell me, and this may pertain to other operations we do for breast cancer as well, not just mastectomy, but lumpectomy, where they'll say, well, I don't care about the scar. I don't care what it looks like. I say, well, we care. We're going to try and make it invisible. And you can't always do that, but there are cases where you can make the scar where it's so hard to find that they wake up in the morning, they don't see it in the mirror, and they go to the mammographer, they can't find the scar, and that's just another day that you don't think about the cancer. So I always tell them, we'll worry about that. It's okay. It's a small part of the operation. But, it takes away a lot. So this is one less thing that cancer is going to take away.
And that's incredible, because I've had some skin cancer removed, and I've had that conversation where you're like, it's okay, I don't care about the scar. I don't care about the scar. But it is, you see the scar and you immediately think and you immediately remember. And it is so nice, especially in your case, you had so much family history. You have been doing self-checks for so long. This has just been a big part of your life. And you're on the other side of it now, and it hasn't taken sensation. It hasn't taken things so much. I mean, it's incredible. I love getting to sit and even hear about it. So for you, completely, like you said, on the other side of it now, you don't even remember the last time you had a zinger. Like, what does this look like for even advocacy or getting the word out and helping other people learn about, not even just the opportunity of the resensation, but breast cancer and the preventative and so much?
It's brought a lot to light for me. One of the things that I've learned in the past year and a half is that more and more younger women are getting diagnosed with breast cancer. And so for me, the advocacy is more, do those self-checks, feel it on the first. And I hate to say this part, but like, check whatever pink products you see in October. Because you're amazed how many products that have pink, or how many companies that use the color pink in October aren't actually doing a whole lot for breast cancer awareness and breast cancer research. And so the advocacy part of it is more of a be more aware of the reality. Like, if I hadn't had the nipple-sparing mastectomy, I probably would have been one of those types of people to want to do a photo shoot where my scars are on display. But I mean, honestly, the work that they have done, you can't see the scars unless I like raise my arms up really high. And like, my husband sometimes will be like, okay, hold on, where is it again? And so like that kind of thing, I still notice it sometimes. So like when we went on a family vacation and I was wearing, I was like very conscious of like the swimsuit I was wearing, because I didn't want to have any sunlight on the scars to protect the scars. But two, I didn't want to have the questions. But I don't think I would have had to have worried about the questions with the scars. But yeah, the advocacy in general is all about like, women are getting it at younger ages, and you need to be more aware of it. And yeah.
and more aware of what is available
Yes.
once you have stepped into that situation. And this is one more thing that is available to just sustain the normalcy, to not let cancer take more than it should.
And, and to speak to your point, it's breast cancer affects 1 out of 8, 1 out of 9 women at some point in their life. And so there are many women that are saying, well, that won't be me. But it's very easy when it's 1 out of 9 to be that next person and have it be you. And, everyone should have a screening mammogram starting every year at the age of 40. But, younger women need to have a sense of breast awareness. If you're 30, do you necessarily need to be doing a breast exam every day? But if there's something new, you just need to call someone and don't wait until your next doctor's appointment. Go right away, see someone, get an exam, get an ultrasound. If you have a strong family history for breast cancer, go see a genetic counselor. We have a certified genetic counselor at the Cancer Center. They can run your risk factors and see what your lifetime risk of breast cancer is. And if it's above a certain number, if it's above 25%, if you're under 40, you may qualify for a yearly MRI. So those are some of the things to keep in mind. If I may, though, I'd like to say, though, that when you asked us about nipple reinnervation and you were in my office, and I told you that we had never done it before, I got the best response from you.
Oh, no.
She said, oh, my goodness, I'm going to be your first. I
I was like, oh my gosh.
you
I'm
are
gonna
the
be
perfect
first.
patient for us.
That is incredible. Well, and thank you for even sharing with us, being open and transparent to talk about your experience, and for you guys as well. Thank you so much for just the partnership that you guys have developed together, but what you are now able to offer our patients here at Centra. And for those of you who are listening, I encourage you to maintain that strong relationship with your primary care. And when you do take preventative steps, invite them into the conversation. And should you find yourself in this situation, I hope this provides a sense of hope and just comfort in this team that can surround you. And so you can check out, I know WSUT has done a story as well with some more details. And we have some information on our Centra Today newsletter as well. If you have any questions, you can reach out to us on social channels. But thank you so much for joining us on Centra Scripts.